Welcome back, guys. Today our topic is Placenta Accreta. Next we will study Vasa previa and then placental hormones. So please like and subscribe my channel. So let's start. Placenta Accreta. This is definition from Datta. It is a condition in which the placenta is abnormally adherent to the uterine wall due to partial and complete absence of decidua basilis, resulting in failure of placental separation after delivery. So there are basically two risk factors, main reasons, as you studied about the Nita book, layers and decidua basilis. So absent of both these, it can lead to placenta accreta, percreta and increta also. Now come to its etiology. Normal implantation, as we discussed, placental villi attached to decidua basilis. It acts as a barrier and prevent deep invasion. But due to defective decidualization, chronic villi directly attach to and or invade the myometrium. Most common risk factor is previous uterine scar. Now, its type, as we already studied, placenta accreta, increta and percreta. So come to the risk factors. The most common and mostly asked in the exam, that is previous C-section. The second most common is previous placenta previa. It's placenta previa. Then previous any uterine surgery, that is dilation and curettage and myomectomy. Then it can be multiparity and assisted reproductive techniques. Clinical features, it is usually asymptomatic, but after delivery there is failure of placental separation, postpartum hemorrhage, and patient can go in the shock. Then how we can diagnose it? Antenatal diagnosis, we can use ultrasound Doppler. In the ultrasound is basically the investigation of choice. In the ultrasound, there is a loss of hypoechoic retroplacental zone. Placental lacunae are seen, increased vascularity and breathing vessels. In MRI is gold standard. It is used in case there is posterior placenta and suspected placenta percreta. Its diagnosis is made in two different conditions. First, it is antenatally diagnosed, then we plan delivery at 34 to 34 weeks and elective C-section is planned. Placenta left in situ, and then we do hysterectomy. If patient wants a uterus preservation, then placenta left in situ and we do uterine artery embolization and close follow-up. It is clearly mentioned methotrexate is not routinely recommended. Now, if placenta accreta is not undiagnosed, it means diagnosed post-delivery, then it can cause severe postpartum hemorrhage. Then avoid forceful placenta removal. It's resuscitation plus uterotonics, and then we do emergency hysterectomy. Now come to Vasa previa. Its definition also according to Datta. It's a condition in which fetal blood vessels unsupported by Wharton jelly run through the fetal membrane in the lower uterine segment, cross and lie close to the internal os. Now its pathology. Basically, fetal vessels belongs to, there are three types. First, velamentous cord insertion, connecting vessels between the lobes of bilobed succenturiate placenta, and these vessels are unprotected by Barton's jelly, lie within the membrane and can easily compressed and ruptured. Second, membranes can be ruptured during onset of labor. If membrane rupture, then fetal vessels tear, acute fetal hemorrhage, and since total fetal blood volume is small, even 30 to 50 blood loss can be fatal. It results in fetal hypoxia, bradycardia, and it can cause intrauterine fetal death. Then risk factor: velamentous cord insertion, succenturiate placenta, bilobed, low-lying placenta, IVF, and multiple pregnancies. Clinical features: after rupture of membrane, painless vaginal bleeding, fresh bright red color, and immediate fetal distress. How we can diagnose it? We can diagnose it antenatally. Then transvaginal color Doppler ultrasound we can do. It shows the fetal vessels crossing the internal os. Then management: after diagnosing antenatally, hospitalization done after 30 to 30 weeks, and we do elective LSCS at 34 to 36 weeks. The important point: it reduces the perinatal mortality from 60 to less than 10%. If Vasa previa are diagnosed during labor, then immediate emergency C-section is done. Neonatal team should be ready for resuscitation, blood transfusion, and prognosis. So basically what you have remember, in case of placenta accreta, the investigation of choice is ultrasound and gold standard is MRI. Placental lacunae are seen. Then if patient wants to uterus preserved, then remove the placenta as much as can, embolize the artery, and then close follow-up. If patient doesn't want preserve uterus, then we can plan elective C-section and then we do hysterectomy. And if we find post labor, then we do emergency C-section. In case of Vasa previa, you have to remember they are the risk factor: velamentous cord insertion and previous C-section and placenta previa. Then how we can diagnose it? We can diagnose it by antenatally color Doppler, and at the time of bleeding we can also do single alkali denaturation test, which is not done nowadays. It differentiates basically fetal and maternal blood. Fetal blood is HbF and it is resistant to acid and alkali, but maternal blood is sensitive. So if there is no change in color, then it is fetal blood. So in this case also, Vasa previa, we didn't try vaginal delivery, we do planned C-section. Now placental hormones. Placental hormones, first we discuss the human chorionic gonadotropin HCG. Its main site of production is syncytiotrophoblasts, glycoprotein in nature. It has two subunits, alpha and beta. Beta is more specific and it is anatomically similar to LH, FSH and TSH, but functionally it is similar to LH only. Now it maintains the corpus luteum. stimulate the fetal Leydig cells to release testosterone, immunosuppressive effect, and it help या फिर it's basis of the pregnancy test. We can detect it 8 days after fertilization, day 22, and it peak 8 days after fertilization. It peak at 8 to 10 weeks. Now it's high in molar pregnancy, choriocarcinoma, and low in ectopic pregnancy. It is so important. Most MCQs asked on this basis. Then one more thing, in case of ectopic pregnancy or in case of bleeding in the first trimester, UPT positive, we repeat the HCG after 48 hours. If HCG doubles, it intrauterine pregnancy. If its level increases, it's and doesn't double, it's ectopic pregnancy. And if its level decreases, it's an abortion. Now human placental lactogen, it is also known as human chorionic somatotropin, HCS. It is a polypeptide hormone. It's similar to growth hormone and prolactin. It has most important is anti-insulin effect, maternal insulin resistance, and lipolysis. Then progesterone. Progesterone source is corpus luteum till 10 to 12 weeks. Placenta thereafter self-formed. Then its function, it maintain the pregnancy, prevent the uterine contraction. Most important, during pregnancy, progesterone prevent the uterine contraction. So at the end of the pregnancy, progesterone level decreases. Now estrogen. Placenta can't itself form the estrogen. When the fetal adrenal gland form, it secrete DHEAS, then it form the estrogen. But it helps the uterine growth, uteroplacental blood flow increases, breast ductal growth, and cervical ripening near the term. Most important estrogen during pregnancy is estradiol, but the most specific one is estriol. Now estrogen can be increased in erythroblastosis fetalis, Rh incompatibility, and it is decreased in anencephaly, fetal demise, and Down syndrome. Now relaxin. Its function is soften the cervix and relax the pelvic segment. Uterine contraction inhibits in early pregnancy. Then placental CRH, corticotropin releasing hormone. Its function is increases the cortisol and prostaglandin levels and do the initiation of labor. And the previous year question, it is act as a placental cloak. So that's it guys for now. Placenta topic ends here. Next we discuss ectopic pregnancy, molar pregnancy. Thank you.